So Dr. Katherine, thank you so much for coming in. I think it'd be good just to let people know how long you've been a doctor for and your medical experience.
Yeah, so over 20 years, and I mainly do fertility care, women's health. I love being a GP. I'm very passionate about caring for pregnant women. And over the last 20 years, I've done a lot of pregnancy counselling for women in crisis pregnancies.
Okay, thank you. I think the first question I've got for you, because a lot of Australians just don't even understand what abortion is. I used to be pro-choice partly because I thought it was necessary for women, for their freedom and empowerment, but I didn't know what abortion was, and it was only learning it that helped change my mind on it. Could you just explain to us what an abortion is?
Abortion is a procedure either done medically with medication or a surgical abortion, which is done with the intention of ending the life of that baby. And in New South Wales in 2019, the change in the law has meant that abortion is now allowed up to birth for almost any reason. There were many amendments that they tried to get through to decrease the damage, but they were not passed. So things like giving pain relief to the baby in a late-term abortion, that amendment fell through. Things like sex selection, abortions being banned in the law, that amendment did not get through. So it is one of the most extreme abortion laws in the world. For example, India and China do not allow sex selection abortions. Most countries in the world promote and respect freedom of conscience. Australia is a signatory to the United Nations Declaration related to freedom of conscience, freedom of religion. The Cones Bill, the Greens Bill currently before New South Wales Parliament, is a massive attack on freedom of conscience. It will deliberately make doctors who don't want to participate in abortion through active referral of abortion or doing abortions, it will put them on the wrong side of the law, which is not the way that medicine is supposed to be. If this new law goes through, it's going to make it harder and harder for staff, both doctors and nurses, to not be involved in late abortions. We all know that early abortions, that medical abortions are available on telehealth. So first trimester abortions, access is extremely easy. There are hundreds of millions of dollars being spent on telehealth. For the Greens to say, oh, there's a problem with access to abortions, in terms of early abortions, it's never been more widely available or advertised or funded.
Wow. And so there's this narrative around abortion access that the Greens have been pushing, particularly with left-wing media, with the ABC and the Guardian, and some academics as well, working together. I've sort of uncovered this on my YouTube show, that there's clearly a campaign going on, ideologically driven, around this notion of access. I have a theory as to what's really this is about, but I don't want to put words in your mouth. But I'll tell you my theory in a minute. What if it's not about access? Because as you said, anyone can get an abortion either by rocking up to a public hospital or getting it via telehealth. So you don't even need to have a public hospital that performs abortions close to you. What's this really about for the Greens?
This is really about trying to get more abortions, especially more late abortions. It's very clear that in New South Wales we have a shortage of GPs, we have a shortage of obstetricians, we have some of the most dedicated, wonderful doctors and nurses working in rural and regional areas, but the workload is huge. They're doing great work, life-saving work. Many of my colleagues in rural and regional areas say that if the Cones abortion bill goes through in the next few weeks, they are very likely to be targeted. They're very likely to lose their jobs because they don't want to be doing late abortions. They don't want to be pressured in the hospital that they work to be doing abortions. And they also don't want to do an active referral because they feel like it's participating in an abortion. It's the first step of organising an abortion. If you had a knee operation, you saw your GP writes a formal referral to the specialist. That is part of the process of that surgery. That is helping with that. Many doctors, including myself, believe that abortion is the deliberate killing of an innocent human being, and we don't want to be forced to do abortions. We don't want to be forced to organise an abortion through a formal referral.
So my theory is it's not about access. You said it's about more abortion. I also think it's about destigmatising abortion, as in really trying to force us to all comply with their religion, which is that abortion is healthcare and you're not allowed to be opposed to it because it's healthcare. And I feel like that's the ideological agenda behind it. They want to completely override institutional and individual conscientious objection because they have a view that you shouldn't be able to object to it. And so I think it is about more abortions, and there's certainly a big abortion industry in our country which makes money off this, and there's big powerful players. But then there's also this issue of they actually just really want to change the culture, and they want to change the law, and they want to change the culture, and they want to force everybody to comply. And there's an authoritarian element to this, which is frightening. And it has implications for not just conscience rights, but also free speech and also freedom of religion. You just mentioned that there could be really serious implications for people in regional and rural areas, and that's something the Premier has also said. He has said that he won't be voting for this bill if it was to pass. It could lead to greater shortages in rural and regional areas.
Absolutely. Which
makes me think, why are they just not blocking it in full? And hopefully they will. Hopefully that is something that will happen. But something I wanted to ask you as well is, do you think there's a lot of fear in the medical profession about speaking up? And the peak bodies, to me, like AMA and RANSCOG, have been quite aggressively pro-abortion in recent years. They didn't originally operate like that, but in recent years they have been pushing abortion up to birth. They use the vernacular of abortion care. And I wonder what it's like for the ordinary health worker.
I have spoken in the last few years to hundreds and hundreds of nurses and doctors, many of whom are in the public hospitals, who feel that they don't have a voice. There is usually in their contract a clause that they are not allowed to speak to the media. They're not allowed to go on social media with their concerns.
I spoke to a young woman who got pregnant unexpectedly at 22, and she said that the abortion clinic in Adelaide kept ringing her to arrange the abortion. And something that I think of when I see Amanda Con's bill is that it's shoehorning women, it's funneling them into abortion and forcing a doctor who has a conscientious objection to actively transfer that woman to someone who will perform that abortion and kill that baby. And there's just no time. There's no space, for a woman to make that decision freely. The UQ study that came out recently showed that I think it was close to 1 in 2 women who get abortions in Queensland are victims of violence. And so the abortion is another act of violence on top of that, killing that child. It doesn't actually deal with the root issue of the woman and the violence that she's experiencing. She's still then just being sent back to the domestic violence situation, but just with a dead baby, on her conscience. And in South Australia, they now don't report this data, but up until 2 years ago they did, and it showed that 95% of women going in for abortions, and there's about 5,000 abortions in South Australia every year, 5,000 babies killed, 95% are for a mental health reason, and yet the resources for mental health for women in pregnancy, I know this because I struggled with postnatal anxiety, and that manifested in the pregnancies that I had. And when it first came up, I called for help, but no one could see me until actually after the baby was born. And thankfully I was very convicted that I was not going to kill my child. But if I didn't have that conviction on abortion, it would have really been a serious threat to my child, and yet all it took is for some counselling to really help me unpack what was going on and to sort of get some things straight in my life that I needed to get straight. And that did take some time to work through, but ultimately I now have a child that is alive and thriving, and I've dealt with the root issues. And so I really hear what you're saying. I think it would be really useful to have you speak in your own words about what each of the abortion methods look like, because I think there's a lot of confusion about various abortion methods. Would you feel comfortable speaking to us about what is you referred to a medical abortion. I've heard that I referred to as a chemical abortion or abortion drugs. What does that look like?
Well, in first trimester, there are very widely advertised both telehealth and face-to-face abortion clinics that mainly offer at that stage medical treatments involving mifepristone and misoprostol, which are packaged often as MS two-step.
And they're tablets, aren't they?
They're tablets.
Yeah.
They do list side effects and the fact that it's not always 100% effective in an abortion happening.
What do you mean, the baby can survive?
Well, if someone were to take the first one or two tablets and then change their mind and not take the other tablets, the pregnancy has a greater than 25% chance of continuing. And both of those medication, mifepristone and misoprostol, are teratogenic. They cause abnormalities to the baby, potentially, such as heart and lung problems, kidney problems. And that is one of the reasons why there's often documents the abortion providers get them to sign that they want the woman to agree to a surgical abortion, and they want to send them to a clinic or a hospital to guarantee that they will follow through. And I think Roussel Uclaf, the company involved in first making RU486, which is also called mifepristone, was concerned about litigation. I think that's part of the push for this push to get more hospitals involved in abortions, concerned about litigation. But the other later forms of abortion, so really you can't usually use tablets only when you're beyond 9 weeks, and that is the second and third trimester, have various techniques which I won't fully describe. It's probably would be considered X-rated material for them to put a third trimester abortion on television. It's really quite an awful procedure.
I describe it. Like, I talk to people about it because I think women need to know.
Yes, and look.
I mean, can I tell you how I describe it and tell me if it's accurate? They inject the baby's heart with digoxin or potassium chloride. The baby has a heart attack, which would be painful, and then they induce labour. The mum takes a drug. She gives birth vaginally to a dead baby. Is that an accurate way of talking about it?
It is, but sometimes the baby is born alive.
Yeah.
And the current New South Wales health guidelines say that if a baby is of a viable age, and we're talking normally 25 weeks up to 40 weeks, that if the staff think that baby has a reasonable chance of survival, that they're to treat that baby with dignity and care. But a lot is left up to the doctor and the midwife involving the late abortion, and we know from some of the studies and from the testimonies by nurses and doctors that a lot of these little babies are left to die. And it can be very distressing to the parents to know that their baby is born alive and then left to die. The proponent of this, a very influential ethicist who I've debated with on television, Professor Peter Singer, in his book Practical Ethics, justifies abortion up to birth and infanticide. And I think a lot of the abortion providers, when I have talked to them, they are justifying infanticide because they know a small percentage of the babies will be born alive, and the purpose of the procedure is to end the life of that baby. But you can imagine that if you're a midwife or you're a paediatric registrar, you're a doctor looking after children, and you are called to see this little baby who has survived an abortion, who's alive, you will feel that you want to help that baby. And I think that politicians need to understand that the 2019 abortion law reform bill did allow abortion up to birth, and it makes it very difficult for even the doctors at the hospital, the obstetricians. After 22 weeks, there's normally a specialist doctor who then consults on the phone or in person another doctor, and the two doctors saying that there are grounds for the woman having an abortion, but the grounds are so broad. The description of the future financial, social, psychological, physical, they list so many grounds that it makes it very difficult for the doctors to say no to a woman who is very advanced in the pregnancy requesting a late-term abortion because of this extreme abortion legislation. And the Cone Bill will make it even more difficult for those doctors. I don't think nurses should be involved, left to do abortions. That is another thing in the Greens bill, that they're trying to get nurses and midwives to be fully responsible for abortions. These are very complex cases. You might have, for example, a woman who has a mental health issue. She may have severe depression and be, 30 weeks pregnant, and she may need a full medical assessment and treatment for her severe depression rather than just being rapidly put through a late-term abortion, which has much more risks than the earlier abortion. So we're talking risks of bleeding, risks of infection, risks of things like amniotic fluid embolus, which can be life-threatening, as well as the psychological trauma of the dilation and evacuation. Basically, it's like going through labour, but the woman saying that her baby's died. So this is not something that should be left to nurses, and it should not be pushed onto our hard-working GPs and obstetricians in remote areas who have a conscientious objection to doing late abortions. They should not be forced to do that. I agree with the president of the AMA, Dr. Katherine Austin, who is an obstetrician. She's spoken this week about the AMA not being supportive of mandating all doctors to provide the service of abortion. If I could give an example of how tough it is in rural and regional areas, I've looked after some people when I've been doing the locums as a GP. One was on Lord Howe Island, so there's a little 3-bed hospital. The doctor who does the locum has to drive the ambulance, do all of the medical care, do some dental care, and work the x-ray machine and often cook food for the patient in the 3-bed hospital. That happened when I was doing a locum there. To put demands of the Greens to say all these regional areas, small regional hospitals need to be doing abortions, providing abortions, late abortions, is outrageous. It is too much. And those doctors put in that situation, overburdened with being pressured to do late abortions, if this bill goes through, they will leave. They will leave, or if complaints are made by pro-abortion people and they're brought before the medical board and they're censured and told they're breaking the law because they have to be involved in abortions, it not only impacts people wanting abortions, it impacts that whole community. You're talking thousands of people who are being looked after by that doctor. All of a sudden, they don't have a doctor, a GP,